So I'm Ming Lim. I'm a pediatric neurologist and I work at the Evelina. I'm sort of head of service at the Evelina, so I do quite a lot of general pediatric neurology, as well as my interest being in predominantly the neuro-inflammatory conditions. And I sort of lead the R&D department here as well, so I have a fair sort of portfolio of studies that I sort of oversee from an R&D perspective. But what I hope to share with you today is the spectrum of virus-associated brain inflammation or neurological syndromes. And when Ben set the topic out, he had suggested that I talk a little bit about the longer-term outcome as well, but I've carefully not put that in merely because it is very, very poorly studied, and actually there isn't as much information out there, but I'll try and sort of provide you a glimpse of what is going on. So I think key to all forms of virus-associated sort of inflammation is thinking about neurovirulence versus neurotropism. Tropism meaning how likely is it to get into the brain, of course, and you've heard of all the neurotropic viruses, essentially the herpes group of viruses, and a few other groups as well. And virulence meaning how severe it gets when it gets in, and we may talk about it a little bit more when we talk about COVID, when we talk about influenza, whereby some of them is actually not as tropic, but if it gets in, it causes a big problem. And the spectrum of conditions that we see in pediatric neurology as that's attributable to a post-viral or a virus-associated syndrome. And I hope to provide you a slight sort of framework to think about this. And like all things, there's always the, why is it happening, to me, why is it happening in this specific environment, and, the genetic and environment that comes in. And I'm just going to allude some of the key developments in the last few years in our understanding, of that. So I'm going to take a step back and tell you a little bit about these two gentlemen here. And if my screen will allow me to, So there's Paul Ehrlich and a Russian chap that many of us cannot pronounce the name, but essentially they were the two forefathers of our understanding of the adaptive immune system and the innate immune system, and both about 100 years ago thought that their version of the immune system was the most important and perhaps only existed, whilst the others was just a different version of the immune system interpreted differently, because as you know, at that time there was no way of visualizing these cells other than means of measuring the effects. So it was the physiological effects of the cellular and humoral response. And of course, as the decades passed, and this is Ralph Steinman. He unified, the two, and some of you who have done, immunology more recently, I certainly didn't learn this at medical school, more recently would recognize that, he was one of the, in fact, the only person who is posthumously acknowledged to be a Nobel Prize winner, identified the dendritic cell, which is the cross-talking cell between the innate and the adaptive immune system. And this has really been the key revisited this time around, particularly in the last 2 years in the COVID pandemic. People have been studying various components of the innate adaptive immune system and how they interact. And this is what essentially it looks like. You have the innate immune system, which is the automatic system. It's upregulated across a whole host of things, from trauma through to infection. It's rapid, it's first line. By contrast, you have the adaptive immune system, which requires a prior recognition or a prior exposure to a protein, or usually a virion, before it then can amplify the response, albeit slightly, delayed, and they have slightly different effectors. You would have heard of the, the lymphocytes in the adaptive immune system, and the, phagocytes and the neutrophils in the innate immune system, and also the different components they use to talk to each other. And of course, it makes sense that complements that have dual effects on the innate and adaptive immune system are either likely to influence both, or be the potential for where the crosstalk can happen. And that little cell that you can see right in the middle there is the dendritic cell, and commonly in the periphery you have the highest number of dendritic cells in your liver, the Kupffer cells. And of course, as things progress, we start to recognize that actually there are some cells that have characteristic of both, and that's your NK cell, your natural killer cells. So natural killer cells would just kill anything along the way, but they appear to have a memory of things they have killed previously, and also the gamma, delta cell. So very quickly moving on, so that this doesn't become an immunology talk that even I struggle to understand. From a clinical perspective, whenever you have an upregulation of the innate immune system, that it goes out of control, it's deemed or called auto-inflammatory. And if it's the adaptive immune system that has gone array, it is deemed autoimmune. So just to be careful, to distinguish, both of them. So how does this all fit into, what we're going to talk about today? The additional component that I didn't mention or have not shown you is that in the brain, there is a slightly different response to innate upregulation, in that the two key glial cells, your astrocytes and your microglia, are the key components of your immune system, but they also have a second function of supporting the neurons. So they are neurobiologically important as well as biologically important. So when one thinks about any response to a virus, we think about the direct infectious effect of the virus. We think of the immune response to the virus creating an inflammatory response. So many people term this as infectious. And in fact, the conditions that I see the most are the post-infectious condition, whereby the child, after having had a viral illness, recovers and then has a second phase. And this is almost certainly an adaptive immune response that is upregulated, that then causes autoreactivity or some breach of self-tolerance, to then cause the secondary or the second phase of neurological syndrome. And I'll give you examples of those. And if you think about the different conditions that you would have heard about, and I've listed some of them there, like transverse myelitis, like encephalitis, but we'll go through them in slightly more detail. The typical one is ADEM. This is a polyfocal inflammatory condition, usually demyelinating, but not always, whereby it is very clearly occurring at the time as patients recover from an intercurrent illness. Sometimes you don't even identify it and you assume it is there. And then GBS being spanning across, i.e. you get a GBS version of viral infections like CMV, where it is more axonal, whereas the more typical demyelinating GBS is probably post-infectious. But we don't usually find the virion or the infectious agent other than in very specific situations. And both these reviews actually were reviews in how COVID affects the brain, and this is how we frame the thinking about all the inflammatory response, and to think about the direct response from the virus, the response from the virus peripherally up-regulating systemic inflammation, as you can see there, that then spills over into the brain, and all the net effects of that, all from multi-system, from platelets, from thrombotic tendencies through to breach of blood-brain barrier. So it is quite a complex, orchestration of various, components, primarily driven by the virus, but not necessarily driven by the virus in the brain in its own right. Okay, so that's how I would frame any form of infection-associated neurological syndromes. The key one, or the three I'd like to sort of group and discuss today, because they typically fall into this spectrum of what we call virus-associated neurological syndrome. One is the virus-associated encephalopathy. The second being the most obvious, being, it's an infectious encephalitis itself, and we won't spend too long, talking about that. And then the third being the autoimmune encephalitis. So these are the ones a little bit like ADEM, whereby after being well, you then catch a second illness as such. So this being a clinical audience, it's always good to start with some clinical examples. And I think because the files are quite big, there's going to be a slight lag. And this, when it allows me to, you will see a history of a child, very typical of an infective encephalitis. So this would be a child that presents with a seizure, having been febrile and unwell, and this then is a focal seizure. I'm still struggling with this. Yes, and I knew it was going to happen. It was all accelerated, and I gave you the answer essentially. And this is a typical example of a child with herpes simplex encephalitis, and this is a focal destructive change, the destruction from the neurovirulence of the virus itself, and there's a big inflammatory component here. So for those of you who are unaware, but for some of you maybe who've worked, in adult practices, the Liverpool team are at the completion stage of a randomized controlled trial of patients with HSV being also randomized to dexamethasone or not. So, you can treat the inflammatory component of an infectious, condition as such. And this trial made a good clinical improvement by the standards of a neurologist rather than by any other, standards, and was discharged, 4 weeks later, but clearly with, a HEMI, but clinically significantly better, and relapsed at 40 days with a loss of skill and a dyskinetic, movement disorder. We looked at the brain, and this was seen as an evolution of the original change. So when you look at that scan, you might be a little bit more alarmed, thinking, there's more, bits of the brain, being affected. Could this be progression, of the virus? And what we would do is rescreen and retreat with acyclovir, and despite that, there was no evidence of viral reactivation. So again, remembering that this is a child that got better from infection, proven herpes simplex encephalitis, subsequently represented again with a second neurological syndrome. This was about 10 years ago before we recognized what this was. And this is the child, as you can see here, with the dyskinetic movement on the left side. This is subtle because this is during the recovery component already, and this was the child before going home during the second event. So we didn't do anything for 3 weeks other than treat it with acyclovir. But unfortunately, over the course of the next 5 to 7 years, she had 3 or 4 other episodes of recurrent encephalopathy, which we again assumed to be a viral reactivation of sorts, and has been left in a pretty damaged state, as you can see there. And what then became very clear is that the second phase of illness is a different form of inflammation, and this is associated with NMDR encephalitis. It's very well described now that after herpes simplex encephalitis, you get a second phase of brain autoimmunity. It's usually NMDR, but other antibodies have been reported. It typically happens 3 or 4 weeks after the recovery, so hence a very good post-infectious component. And the younger you are, you do more poorly, and it's pretty well described now. And you treat it as if you would treat NMDR encephalitis. So rather than treating, the virus itself, of course, there's always a concern that if you throwing a lot of anti-inflammatories and disease-modifying treatment like rituximab, there is a worry about viral reactivation, in this group, and you may have to cover with some, acyclovir, but very few, if any, of the cases reported have had problems with subsequent reactivation of herpes virus. And I still recall a very poignant discussion I had with a virologist that worked with us many years ago. And I think these sort of statements only come from people who've worked in the NHS a long time ago, who told me that the difference between herpes and a marriage is that herpes is for life. So it lies dormant in your dorsal root, ganglion like varicella, and then can get reactivated, at a later time, as such. So you have to worry that if you're giving a lot of immunosuppression, that you might have to have antiviral, cover. So this is another clinical story of a boy presenting with an upper respiratory tract infection, and as he was becoming febrile, had status. And of course, if he was younger, you would have been, assuming that this was febrile convulsion, anyway. But he's older, so something is not quite right. As you can see, there's also systemic involvement, particularly in his liver function, abnormality. And if you scan him, you can see the huge, blobs there, and that's his thalamus being very swollen, and some bits of his brainstem, as well. And this is influenza associated. So this is the beginnings of me describing the range of virus associated encephalopathy. This happens at the time of the viral infection. It's still a little unclear as to whether this is direct neurotropism, i.e. the influenza stuck in that thalamus, or an inflammatory response as a result of the virion very near the basal circulations, as such. And if you look at the spectrum of virus-associated encephalopathy, you probably have the milder end of the spectrum being the febrile seizures with just on its own, and the opposite spectrum being the herpes, the hemorrhagic, shock, encephalopathy syndrome. And the patients in between, and two very distinct syndromes. One is acute necrotizing encephalopathy, which I will briefly touch on. And then there's a second one whereby children have a biphasic presentation, initially of the focal seizure, and then secondly, as they wake up from intensive care, and we never really know whether it's because of the masking of the clinical state because of all the intensive care treatment, or whether it is actually a proper, biphasic, but you get a second seizure flurry, often associated with this very characteristic change of restricted diffusion on the scans. And whether this is inflammatory or whether this is some odd form of excitotoxicity, I think it remains, unclear. So let's see how we define them. Yeah, this slow reveal isn't working on my system today. I'm sorry. So this is a 2-year-old boy with an upper respiratory tract infection, and then becomes progressively, encephalopathic, and also has a left, hemiplegia. And I suppose if you saw that, the common differential would be, would this be something like, ADEM? But of course, because the child was acutely febrile, at the time, as the encephalopathy ensued, would make us worry that this was more of a virus associated at that particular time. So a infective or a para-infective or para-infectious encephalitis as such. Also had some systemic, involvement, as you can see there, and a slightly high CSF protein. And these are, fairly characteristic changes that we see as a neurologist, identifying, the external limb of the internal capsule, which are these bright, areas here, concurrently bright on just a different, sequence of imaging. The temporal lobes are being hit, and in this particular child, the spinal cord is also involved. And if you look carefully at a blood sensitive sequence, there's a little bit of hemorrhage in some of these lesions. So I think this is due to influenza during the H3N2, but it could be replaced by any strain virtually. And I hope that if you were to remember that spectrum that I showed you, this would probably be closer to the ANEC stroke hemorrhagic leukoencephalopathy type spectrum. This is another child. You can see near similar picture. Maybe the protein isn't as reactive. And this is the typical pattern that I was describing, where there is a restricted diffusion in the white matter. So this is very, very odd. We see that sometimes in patients who've had a double hit of hypoxia, suggesting that maybe there is something inherent about the excitotoxicity in these patients, or the susceptibility to excitotoxicity, rather than inflammation in its own right. And again, this is due to influenza, and this is what is ascribed to this condition, usually recognizable by the imaging. But what I was also hoping to show you is that the spectrum is wide. You may get a few conditions, a few areas of just restricted diffusion, and other thalamic involvement in some patients as well. So you have a crossover. So as to not this becoming a talk about how to recognize this condition, I just wanted to give you an idea of how treatment, or how COVID has helped us move this field very, very significantly. Historically, all these sort of armories that we have are directed at first line treatment, is steroids, IVIG, and then if you're very severe and if you happen to be in the right center, predominantly a neuroscience center, you might have access to plasma exchange, and you would do that for all these patients. But despite that, patients did very, very poorly. And the Japanese have the biggest group of patients with this condition. And what they started to do was to try and define, the severity. The details not important of the severity, but just to show that age is an important factor, as well as systemic involvement. And the more systemic involvement you have, the more likely you are to do poorly. And this is to introduce the concept of tocilizumab, that has now become the new smartie in most treatment associated with COVID. But this is a 9-year-old girl with a very high score. And this is a scan, and you would predict based on this scan that she would do very poorly. But the only difference between the treatment of her is that she had tocilizumab, pretty early. And this is a picture of her 9 months afterwards with a near full recovery. And this is from a colleague in Singapore who first introduced us to this concept about 5-6 years ago now, but never really taken up very much. And this is the stark, just a reminder to all that, the plural of anecdote is not data, but in very rare, conditions, sometimes an assimilation of all this data is all we have to go by. And I hope you could look at the charts there. The panel on your, I suppose if you're looking at it now, it's still on your left. And the panel on the right is their attempts to provide some neuroprotection, as well as very early IL-6 blockade in this group. And I hope you can see here that although it's compared to the historical control in a Japanese cohort that is slightly different, patients who have the high risk score that were invariably very severely damaged or died that was the exception to the rule in the Malaysian and the Singaporean cohort, where IL-6 or neuroprotection was given, early. And this, as you know now, is what we do with patients with very severe COVID, and some of you who are familiar with the PIMS-TS patients, and in the recovery trial, COVID is a recovery trial of COVID treatment. Tocilizumab is one of the lower, arms, and now, and we of course await the results of that in children in the pediatric, group. So I wanted to stray a little bit to talk a little bit about what promotes chronic inflammation after having had an inflammatory hit or susceptibility to inflammation, and then come back to a little bit about COVID. And if we have time, I wanted to talk about a worrying, perhaps emerging a syndrome affecting the spine. I think some of you might know already. But okay, going back to what promotes chronic inflammation, there's only three things, isn't there? There's genetic, there's environment, and there's actually genetic and environmental interaction. And here it's written as to whether there is an immune, dysregulation that is independent of the genetic and the environment. I don't think there is, but these are, what's, proposed out there. And this is very much along the MS, model, but I think an important model as such. And the genetic predispositions are either monogenetic, so you have the mutation, you have the innate immunity, auto-inflammatory, condition, and this range from Aicardi-Gouttiere, from the interferonopathies through to the more esoteric, very specific IL-beta associated mutations, where you get very much a Aicardi-Gouttiere-like syndrome from chilblains. And in fact, you're being general pediatricians and also having specialties outside the neurology may see more of it than I do. I only see them when they affect the brain, and most of our rheumatology colleagues are very well versed at looking after these children. And then there are some examples whereby the adaptive machinery also is affected, whereby single mutations can make you more susceptible to recurrent multi-system, multi-organ, autoimmunity that runs, in families. But these are, very, very, very small print as such. And if you look at the virus itself, you have TRP mutations, and you have, this is another example of an RNA mutation with susceptibility to brainstem, viral infections. So they're either your sensing mechanism, whereby you can get an over reaction, or some form of viral clearance. And that's becoming very interesting for some other conditions as to whether the lack of clearance is the reason why you have an upregulated immune response, or you just have a perturbation of the sensing mechanism, that the minute the virus hits it, you have an over amplified immune response causing the problem. When I mean immune, it's usually an innate response rather than an adaptive response. The slide on the herpes of the TRP must have gotten hidden in that process, but I had meant to show that, but it's essentially similar, showing you that it's happening at the level that the virus enters the cell or gets triggered by the cells. And if you look at a range of other autoimmune conditions, HLA association is quite linked. I'm just highlighting the autoimmune ones, but a lot of the other ones are quite well established that doesn't get a mention. And then we come back to the environment again. ANAC is bad when you have influenza. It's less bad with other viruses. And if you have the mutation, which is a RANBP2 mutation, it's a nuclear pore mutation. We don't really know why it happens, but we know that the nuclear pore is involved in the internalization of many viruses, including COVID, but certainly influenza. Why is it just specifically in the brain? Why do we not get this response, elsewhere? That remains to be answered. But because these conditions are pretty rare, and the fact that the original person geneticist that reported the mutation was not able to develop a knockout mouse, for this, we've not been able to study it as well. But was just recently at an ANEC meeting 2 weeks ago, whereby they've got a sudden cash injection because of the near similarities to studying nuclear pore in other viruses, and of course the most big one being COVID. But we have observed for many years now that if you have this condition, particularly of the genetic mutation, and if you have influenza, it is significantly worse. So what do we need to do? We need to vaccinate these children. And perhaps the only one condition that we would say that the influenza vaccination is perhaps mandatory or mandatory. And it was just to round up the gene environmental interaction I think a lot of you would be familiar with the concept of, the interaction, meaning that it amplifies the effect. So if you have, an odds factor ratio of, X amount for the gene and an odds ratio of an X amount for the environment, if you see both of it together, if the odds ratio is higher than the summative component, then there's an interaction. And many of those, exist, and you do need big numbers for this, and that's why we always go back to MS. But I think the key important message for MS is that many of these factors are both reproducible in children, although only 5% of people have MS in childhood, but they are operational also during childhood, meaning that you can, if you can try and switch off some of those risk factors to prevent disease, and that's why it's sort of interesting from that perspective. So you might have heard of the risk factors of the latitude being programmed in you up till the point that you are about 15 or 16. So before that, you might be able to move to adopt the risk factor of where you stay, but up till a certain point only. So these are interesting things that environmental interventions helping in some of these conditions, but not forgetting that the environment also is related to the types of sort of viruses that you get. And this is a very interesting study in PEDS showing that actually, in fact, the exposure or the sequential exposure to viruses may be the reason why some patients are protective and some patients are not, in the sense that if you get EBV before CMV, then you have the EBV risk. But if you get CMV before EBV, you might be protected from the EBV risk. So I think this is interesting observations, how it how it sort of translates to clinical practice is more difficult to be sure. And I'm not sure if a lot of you saw this, but this was another example of how big data is helping us unravel some of these associations. This is from a big registry, GP, both GP and I think another registry, I can't remember what now, linking HIV registry, of course, linking patients with the condition to a whole host of other to the MS registry, recognizing that if you had HIV, then your risk of MS is a lot lower. And this created a big sort of interest many years ago now, and it looks like perhaps it wasn't the HIV what is protective, it's the treatments that you put the patients on, and antiretroviral treatments are now being studied as a potential therapy or for sort of MS as such. So I'm going to go back to neurotropism. We know that the neurotropism in COVID is very, very low, far less than influenza, but anyone has had COVID. So even with the very low neurotropism, and this was done a year ago now, where these were the predicted numbers of infection, and this could but what I've superimposed on is what we might think that that these are children who might be infected or might eventually have COVID, and the numbers are going to be high for just because so many people have had the condition. So although neurotropism is low, the prevalence is high because of the number being infected. And you will know that this time last year, during within like 2 months of PIMS-TS being recognized, it's suddenly become a widely acknowledged condition that children get as a result of COVID or in association with COVID. So as you know, some patients were not actively PCR positive, but had COVID or assumed to have COVID because they're IgG positive within the last 4 to 6 weeks. And this is a multi-system condition, very akin to toxic shock and Kawasaki's, or a merger of both symptomatology. I see the aftermath of it when they do have some brain inflammation, but not an expert in looking after the condition, but well aware that during the peak of the epidemic or the pandemic, and the first and second wave, we saw probably about 200 children with that at the Evelina. So what is the burden of the COVID on the brain as such? And a lot of you will know that we're very lucky in the UK that there is a great surveillance unit, and this was very quickly set up by the Liverpool group in conjunction with the BPNSU, which is not quite the BPSU, but the new BPNA, which is the Neurology Association Surveillance Unit, which borrows the same framework, but at a lower number sort of level. We identified very quickly, 50-odd children with neurological syndromes associated with COVID. So this is still vastly, very low, numbers. But if they were sick, if they had them, they were sick. As you can see there, 50% were admitted to intensive care. And of this, it was about 3 to 4% of the entire, COVID admission to hospital. So again, not massive. If a comparator of this would be perhaps about 10 to 12% for flu during the bad, sort of more virulent flu, and perhaps less in the ICU admission for flu, about 30%. And the reason for this skew is because the ITU admission was from the PIMS-TS group. So the spread, as you can see there, is related to, and just to highlight the mechanism, one is that you get worsening because you have got problems already with, an underlying neurological condition. The acute COVID encephalitis is still exceptionally rare, but maybe there was, these 3 patients. If you went through the history more carefully, they were all PCR negative, so you cannot be absolutely sure if it's an encephalitis, but it was definitely an acute COVID encephalopathy. And then half are related to this systemic inflammation spilling over, into the brain. And then you get another group that are, sort of post-infectious. So these are 2 to 3 weeks later, no different than what you would expect for another virus that you substitute there. There's a lot of excitement about reporting the first only COVID career, the first only COVID GBS, but when we come down to look at the way they respond to treatment, it is no different to any virus-associated neurological syndrome. Okay, so I'm just doing a time check in that I'm fast approaching, I think, about 35, 40 minutes already. So I'm going to try and wrap up in the next 5 minutes or so. When you look at imaging of children with COVID and with adults as well, these are the key features. So some of them are recognizable as a post-infectious syndrome like ADEM, the myelitis. But I just wanted to highlight two things. This is the splenial signal change that you can see there, and this is a condition called MERS, which is an mild encephalopathy with reversible splenial change. It's assumed reversible because 1 or 2 have been reported as reversible. We don't repeat the imaging to demonstrate that they're reversible. But very bizarrely, patients do have this cranial nerve enhancement, and they're often asymptomatic from it. It's only from looking. I think that all that reflects is that there is a lot of inflammation in COVID, and this is a reflection, of that, both systemically as well as, in the cranial nerves, peripheral nerves. We know that when children, get into hospital, as this is the neurovirulence, component, the morbidity is significant, and this it can be life, threatening as well. Some are a result of the treatment that we give patients, particularly ECMO, giving you strokes, giving you, metabolic syndromes, or just being very sick. The adults coined a term called toxometabolic, and this is essentially when your urea is high, when you've had renal failure, when you've had liver failure, and if you've had a lot of those, then you are pretty unwell. What we did show in our cohort, a first wave cohort of about 75 patients, was that if you had higher peripheral inflammatory markers as measured by the ones that we usually do nowadays for COVID or for PIMS-TS, procalcitonin, D-dimers, ferritin, and fibrinogen, you were more likely to have a neurological syndrome. Not surprising, spillover into the brain, but slightly more worrying that it took you a bit longer to recover. But we only had at that time 3-month data. And the Great Ormond Street cohort group followed this up very elegantly with a longer term follow-up, albeit in a smaller, group of patients, demonstrating that despite the symptom load, and this is a multi-symptom picture ranging from gastrointestinal through to neurology, and the neurology one is in that blue category. And I think all I wanted to show you was an impression that despite being very sick, by 6 months, very few patients have got, residual symptoms. So they recover, well. And although they report or when you look at them and examine them, they may have some, neurological deficit. They make a very good, functional, physical recovery. But as a lot of you are aware, it takes a toll in other ways. The emotional scales measured that patients do have severe impairment in at least a fifth of them 6 months after the event. The magic sort of or $1 million question is that, is this worse because of COVID, or is this because we're just measuring it? And this is a nice study alluding to the fact that COVID does incur a higher morbidity compared to another virus during the time of COVID as well. So this is not a historical control from many years ago, and across all the conditions that they measured, this was significantly different, but stressing that this is an adult cohort. Long COVID, long neuro COVID in children is very topical, from burden to the NHS through to rationale for vaccination. This was, if some of you had not seen this paper, my colleagues at the Institute of Child Health, together with Professor Spector, used the Zoe app to track all the symptoms in children who've had COVID. So the main weakness, of course, is that this is a reporting based, and we don't know whether it was sampled as accurately or not. But I'm told that they've gone back and looked at the data of the ones that have reported and of the ones that are reported on the Department of Health, and there is some, good, correlation. But the message here is that most children do get better, and very few symptoms persist after COVID, not PIMS-TS, this is after COVID, after 28 days, and in a very, very small proportion, particularly in older children as well, the symptoms may persist beyond 28 days. But this is 1 or 2%, and of course this study now is superseded by the clock study that is run by Professor Stevenson and Shamez, who is the PHE ID consultant, alongside a whole host of other people, and you would have seen the sort of sound bite from the studies, being that 1 in 7 children are affected by an acute infection during COVID, and it is the incidence is pretty similar whether you're COVID positive or COVID negative, but the burden of disease is significantly more if you are COVID positive with multiple symptomatology. This is a preprint that you can find on the preprint website. But I just wanted to end with one thing, is that we at least in neuroscience, have seen a huge shift of change of admissions during social distancing, and we compared it to the norms or the means, annual mean 3 years before COVID and the year of COVID, starting from March, assuming that the social distancing, was the factor. And you can see that a huge drop in patients with autoimmune encephalitis, a huge drop in patients with infection-associated syndromes, but less of a drop with the other ADSs. And the perhaps explanation for that is that the other conditions are either post-infectious or more complex interaction between the gene and environment, or there's a longer lag period before they present. So we will only see the signal in years to come. Perhaps like in diabetes, there appears to be a signal that there's a higher incidence of diabetes post COVID, and we're still unraveling that. But that can happen in some of these neurological syndromes as well. I had prepared something on acute flaccid myelitis, but I'm going to stop there now in case you all had questions, and I know some of you may have to go at 12 o'clock, and if you thought relevant, I could just mention a word or two about acute flaccid myelitis, which is another very typical virus-associated neurological syndrome that is susceptible to changes because of social distancing and the pandemic. So over to the rest of the team to ask any questions. I'm going to stop sharing, but reshare again if need